Welcome everyone to the MRCGP AKT High Yield Revision webinar number 3. So what we're going to do is we're going to do exam style questions covering key topics followed by rapid reviews. There'll be examples of different question formats that you might see in the exam. So we're going to split today's session into 3 parts. Part 1, we'll do 5 interactive questions where I will show you a question. You'll have 55 seconds to look at it and I will launch a poll. Please use the poll to select an answer. Part 2, we will do a timed mini-mock exam. So we'll do 10 questions. But you'll do all 10 in a row and there'll be no polls. I'll go through the answers and explanations afterwards when we've done all 10. And then finally, part 3, we'll talk about how to make the most of the time between now and the exam. We're sort of 8 weeks out to the exam now, okay? So, how to make the most of this critical period, and there'll be a chance for you to ask any questions. So use the Q&A if you've got questions that you'd like myself or the faculty to answer. Use the chat to get involved in comment and discussion. And joining me today from the Core Emega team, we've got Anna Grayted as faculty who'll be answering questions. So we're going to go straight into part 1. We'll do 5 interactive questions, 55 seconds each. We'll do answers and explanations after each one. Okay, here we go. First question. Okay, great. I'll stop you there. So this main split is between A, C, and D. Very few people pick the other options. So what we've got here is an audiogram. Now, any picture question in the AKT, make sure you look at both the picture and the scenario, and by putting them together, it will give you the best chance of getting the answer. Okay, so the correct answer is A. That hearing in the right ear is mostly in the normal range. Now, this is a bit of a strange audiogram because they haven't labeled the ears. And that's because one of the things that's being tested, this one's presented to you in color. One of the things being tested is actually if you know the standard way that audiograms are presented. Okay, so the right ear is always in red in a color audiogram. Sometimes you have it in black and white, in which case it would always be labeled because you couldn't tell otherwise. Okay, but in a color one, the right ear is always in red. Easy to remember, refer red, refer right. Okay, so this is the right ear. And you see, this is the line where everything above that is normal hearing. So you can see the right ear, for almost all frequencies, they're normal. Even this is right on the line of normal. You can see only at the very high, this is like 7 kilohertz, that you just get into a bit of mild loss. Okay, so all the way here is normal, and then right at the top, mild loss. And that's what he says, the hearing the right ear is mostly in the normal range. For almost all frequencies is in the normal range. Whereas if you look, the blue one is the left ear. The left ear, you can see that it's mostly sort of mild, then moderate loss, but then you get in the high frequencies, you've got significant loss here. Okay, so that's why A is the right answer. So I just go through the other 2 popular answers, which were C and D. So why might people have thought that this is conductive? So people might have thought, oh, okay, look, it looks like there's a gap between here and here. In a conductive loss, the gap has to be in the same ear. Okay, I'll show you an example of what that looks like. All right, if there was a red one that was down here and then a red one up here, then the right ear, one of them would show air conduction, one of them would show bone conduction. In this one, we only shown air conduction in both ears. They're not bothering to show bone conduction. That's because in a sensory neural hearing loss, which this is, we don't really care about the bone conduction. It's not important. Okay, so you'll sometimes see they just show the air conduction. In a conductive loss, they'll always show both. All right, so this is sort of mild hearing loss, and then we get to moderate, and then this last bit is sort of more severe. Okay, So bone conduction will be shown by either square or triangular brackets. Again, buffer bone, buffer brackets, okay? Do you notice there's no brackets here? There's circle and a cross. That's again standard denotion that one of the ears for air conduction, they'll show circle. Remember, air passes through a circle. The other one, they'll typically show a cross, okay? The right ear is always red, the left ear is always blue in a color audiogram. So look, here's an example of a bilateral conductive hearing loss. If we look at the right ear first, the brackets show the bone conduction, the red ones in the right ear, and you see it's normal. And then the air conduction is shown here with the circle and the red line, and you can see there's a gap between the bone conduction and the air conduction. That's what tells us it's a conductive loss, i.e. the air conduction is being slowed down, it's been impacted, it's reduced, whereas the bone conduction doesn't change. Let's say you've got a cholesteatoma or a big effusion. Slow down the air conduction, the bone conduction is still intact, isn't it? Okay. Type into the chat, in this particular one, both ears are affected. Which ear shows a greater loss in terms of the conductive hearing loss? Is it the right or the left? That could be another question, couldn't it? Type into the chat. The right, okay? Because remember that the lower you go down here, we got mild, moderate, severe, profound hearing loss. So you can see the red is lower, all right, for most frequencies. So the right one has got slightly more of a loss compared to the left one, but there's loss on both sides. And then this is typical of, do you know which type of sensory neural hearing loss? Is this a typical picture of? Type into the chat. So this is sensory neural. Do you see, look, they've just shown the air conduction. Right ear is the red one, left ear is the blue one. They're not showing bone conduction, just like we did in the one we showed here. This is the typical presentation of presbycusis, the age-related hearing loss, where it's actually normal in the low frequencies. Then you get some loss in the medium frequencies. It's at high frequencies, typically 6 kilohertz and above, you get significant loss. Okay. Right, good. Let's move on to men's health. 55 seconds. Okay, I'll stop you there. So we've got a split between A, B, and D for this one. This is an example of one of the more challenging question types in the AKT, which is that it's a two-stage question, if you like. The question is asking about the most suitable management. But you see, to get the management right, you first need to work out the likely diagnosis, because they've not said the diagnosis is this. From the description, you need to work out the diagnosis. That's the first stage. And then, but to get the actual mark, you then need to know how to manage that condition too. So do you see, if you get the diagnosis wrong, there's a very good chance you'll get the management wrong because you're managing the wrong condition. All right. Sometimes you can get this first stage right, you can get the diagnosis right, and maybe not know the current guideline for the management of that condition and still lose a mark. So it adds an extra degree of challenge. It's also quite long. So type into the chat, first of all, what do you think the diagnosis is? Imagine the question said, what's the single most likely diagnosis? Type that into the chat, and then we'll look at the correct answer and we'll look at what the condition is. Okay, great. So we've got acute prostatitis, epididymoorchitis, orchitis, epididymitis, testicular torsion. Okay, so they're the sort of range of diagnoses. The most common one is epididymoorchitis that people have put, which is the correct one. Okay, so the correct answer in terms of management is D. Treat with levofloxacin, 500 milligrams daily for 10 days. Okay. Now, the really useful clue here that tells us that this is more likely to be epididymoorchitis, a couple of things that are really useful. So one is the age. What kind of age is torsion much more common? Because it has got some similarities in terms of how torsion can present. Torsion you tend to see in younger men, teenagers to younger men. Okay, you can get it at an older age, but it's just not very common. Okay, but then the other big clue is this, that Pren sign is positive. So in torsion, Pren sign is usually negative. So Pren sign is you elevate the scrotum, thereby elevating the testes. And if positive means that the pain goes away. It's relieved by elevation of the scrotum, of the testes. So Pren's is usually positive in epididymoorchitis. In torsion, first of all, you try to lift the scrotum, it hurts so much they won't let you. But if they do, the pain doesn't go away. Okay, so Pren's is negative usually in torsions. That's the other big clue. Okay, now the other useful clue is that he's recently had a UTI and hasn't been sexually active for a significant amount of time, for at least the last month. Okay, why is that useful? Because you can get epididymoorchitis. It can be caused by different organisms. Some that are more likely if you've been sexually active, things like chlamydia, gonorrhea, in which case the management might be different. Others that are more likely if you recently had an UTI, like E. coli or things like that, in which case levofloxacin is the right answer. So that's why the answer is D, levofloxacin. Okay. Whereas, can you see if you thought it was torsion, well, this would be the right management for torsion. All right. Do you see what I mean about two-stage questions? All right. And then if you thought that he's got epididymoorchitis, but it's the underlying causative organism is likely to be related to STI, then you might pick this because you're thinking about chlamydia and gonorrhea. Okay. The other thing that's important, I'll just come back to, and that's to do with technique. Okay. So first of all, how does epididymoorchitis present? You get a gradual onset. It's painful. It's tender. There's a palpable swelling, usually unilateral. There's erythema overlying, and then the useful clue that Pren sign is usually positive. So when you elevate the testes, the pain gets better. In terms of management, if they're really unwell, septic, they might need admission for monitoring and IVs. But otherwise, if we can get them seen within 24 hours by gum, that's great. Otherwise, we can treat it in GP. And you treat based on the likely cause. So if you think that, they might be at risk of having an STI, they'd recently had unprotected intercourse in the last sort of few weeks, then, things that we might be thinking about is gonorrhea, chlamydia. And so then you might be thinking about treating with the things that I've listed there. Whereas if you think that they've recently had a UTI and you think about enteric organisms, they've got a low risk for STI, then you've got options of either ofloxacin or levofloxacin. The key thing is both of these are long-term treatment. Ofloxacin is 2 weeks, levofloxacin is 10 days. If I take you back to the question, a few people, not many, picked C. So you actually got the right drug. But if look, part of the exam technique is reading carefully. A single dose of ofloxacin won't do anything. It's a 2-week course. Do you see? And that's why it's not the drug that was wrong here. It was the dosing. It's just a single dose isn't enough. All right. If this said ofloxacin 200 milligrams for 14 days, twice daily, actually that would work, but it's just not the right answer because of this. Okay. Right. So let's move on to number 3, antibiotics in sore throat. Okay, great. I'll stop you there. Right, so the two popular answers are A and B. No need or offer a delayed script. Now, again, this is another two-step question. So to get the management right, you first got to calculate the fever pain score correctly and then know how to interpret that. So let's do that first. Type into the chat. What's this patient's fever pain score? So we've got so far 234. That's what we straight away kicked off with. So 234. Okay, a lot more people leaning towards twos now. A few more threes. Have we got any? Oh, yeah, we've got a one. Yeah, 1, 1, 1, 4. And then the rest, it's a split between 2 and 3. All right, okay. So this patient's fever pain is actually 3, and that the guideline recommends offering a delayed script for pen V. So B is the correct answer. All right, they're not allergic to pen V. If they were allergic, then you would use something like clarithromycin or erythromycin. So let's look at why they get the 3. So remember that the fever in fever pain is fever within the last 24 hours. That includes measurement at home or self-reported fever. Can you see? So there was 38.1 earlier in the day. They get a point for that, even though they're afebrile now, but that's because they've had paracetamol. You see, that's probably why their fever's come down. So they get a point for that. P is pus on the tonsils or the back of the throat, purulence. They haven't got pus. Look, no pus visible. So they don't get a point for P. A is attending rapidly, attending within 3 days or less from when they started having symptoms. They've had a 2-day history. So they get a point for that. I is inflamed tonsils. Look, tonsils are inflamed. They get a point for that. So that's 3. And then N is no cough or coryza. Now, it's important. Sometimes people get this part confused. They think that if they don't have a cough, that's a point. And if they don't have cold symptoms like a runny nose, that's a point. That's not how it works. If they have cough or they have a runny nose, coryzal symptoms, then there is no point. You only get the 1 point for no cough, no coryza if they don't have either. So do you see, he's got a runny nose, therefore there's no point for that. That's why it's 3, not 4. Okay. So then the interpretation is, now we've gone through what the criteria are. If you score 0 or 1, the likelihood that you've got a bacterial infection, streptococcal usually, is very, very low. So the guideline recommends don't give antibiotics. If you score 2 to 3, then there's a moderate probability of a bacterial infection. So you should consider a delayed script. And if they score 4 or 5, there's a high probability of a bacterial infection. So consider giving antibiotics at the same time. And first line, if they've got no allergies, is Pen V, 10 days. If they're allergic to penicillin, either clarithromycin or erythromycin, and that's a shortened course, it's 5 days. Okay. Let's move on to access to health records. This is part of the admin domain. Okay, great. I'll stop you there. So this one is a clear winner. More than half of you, the most popular answer is E, but quite a lot of people picked either C, Data Protection Act, or D, Access to Medical Reports Act. They're the other 2 popular answers. But most of you, over half, picked E. Okay, so the key thing here is that the patient wants access to someone else's records, his father. It's not someone random, it's his father who's passed away. And it's because, he's the next of kin and he's worried about negligent care. So he might be thinking of suing. So the correct answer is E. If you want to access someone else's record who's passed away and you have a legitimate reason to do so, you're the next of kin or the executor of the will, or in this case, is actually both, then you need to apply under the Access to Health Records Act. Okay, so E is the correct answer. Those of you that picked Data Protection Act, you might have picked that just because you've heard of that one, you're more familiar with it. That's the most commonly used act in relation to accessing health records, but that can only be used to access your own information. So if this patient wanted to access his medical record, not his father's, then he would need to apply under the Data Protection Act. Okay. The Access to Medical Reports Act, 1988, this is for companies that want to access information on their employees, usually to do with occupational health reasons. And then, as we already mentioned, the Act mentioned in the question that if you want to access someone else's records who's passed away and you have a legitimate reason to do so, then you apply under the Access to Health Records Act 1990 for that. Okay, let's do evidence interpretation stats. Here we go. Right. So again, very happy to see most people got this one right. So the three popular answers: Barnsley, Bradford, and then Doncaster. So the question asks for the area that had the worst mortality rate for women under 75. And you can see that we've got England as a comparator, Yorkshire and Humber, the region as a comparator, and we've got different parts of Yorkshire and the Humber, okay, listed here. And then if you look here, this is a good example of the new style data interpretation questions, which are increasingly more common in the exam now. There's no maths here. This is just interpreting real life data. This is pulled from Public Health England. And if you just spend some time getting familiar with looking at these things, it's just speed things up. But even if you've never seen it, if you just read carefully, so you've got good exam technique, you can get there. So look, it asks for the worst mortality rate for women under 75. Do you see here, we've got persons, that's male and female, female, and mortality rate, do you see? So mortality is what they're asking for. But do you see here, this is mortality rate from cardiovascular diseases. Do you see, that's a subset. These will be included within here, but it didn't say cardiovascular mortality rate. So these are only deaths for things like heart attack, heart failure, stroke, cardiovascular related. Whereas this could include deaths for any cause: cancer, diabetes, accident, okay? Any cause, all right? So all we need to do is make sure we're looking at the correct line. So under 75 mortality, female, this one. And then you're just looking across and it says worst mortalities. That's the other important thing to read. So is a higher number worse or a lower number worse? Higher mortality is worse, right? So you're just looking for the highest number. So what's the highest number on this row? Doncaster, 324. So the correct answer is D, Doncaster. Okay. So why might some people have got it wrong? Well, if you looked at the male one, do you see Bradford is worse? If you looked at persons, male and female, Bradford is worse. If you looked at female, but you were looking at cardiovascular mortality only rather than all-cause mortality, then again, Bradford is higher. So is Barnsley. Both are higher than Doncaster. All right. So that's why some people might have got this one wrong. Okay. So, and then, the kinds of data interpretation questions that you can get. So it could be about prescribing data or, regional incidence or prevalence of different types of disease, other types of public health data, like cancer data, demographic data. What kind of age groups are in this practice or in this area compared to other areas of the country? Mortality, subsets of that, cardiovascular mortality, infant mortality. Interpreting research, so more classical stats type questions, so different types of graphs. I'll give you some examples of the kinds of things that you can get access on public health. So this is looking at different age groups, what proportion of patients in this particular practice, the practice that I work at, inner city Birmingham. So I pulled their data. This is antibiotic prescribing for a practice in London. This is called a quinary graph. It looks at different age bands in a particular place. This is infant mortality data. This is a leaf plot, a Cates plot, okay, things like that, okay. So any questions on those first 5 questions before we move on now? We're going to do a mini mock, a timed 10-question mini mock. By the way, all of these graphs and charts that you've seen, we'll cover all of these at our half-day stats course, which is running this weekend. Okay, that's just been updated. I updated that today. We've expanded the number of questions we cover within it. So let me just tell you about those masterclass webinars. So the way we did those questions, where we do one question, 55 seconds, then you pick the answer, then we go through rapid review of the relevant topic. That's how our masterclass webinars work. So we have them live and interactive, but there's also recordings available. So this weekend, we've got Statistics Made Simple, 4 hours covering the key stats topics. Then the same day in the afternoon, we've got Organizational Domain Organized, so the key admin topics in half a day. Next week, in the evenings, Wednesday and Thursday evening, we've got the High Yield Clinical Grammar 1 and 2. That's 3.5 hours each time, so 7 hours in total, 7 p.m. to 10:30, where we'll cover 100 plus clinical topics mentioned by examiners in the last so many years. These are topics that come up again and again. So we'll do those one at a time. So you can book any of them separately. Stats and admin are £125 each. High Yield Clinical Grammar 1 and 2 come as a set, okay, at £198. Or you can book them all for £299, so saving nearly £150. The recordings are also available at any time for instant access. Anyone on our Pass Guarantee program or Pass Plus program, you already got all of these included. You will already be booked for them. Okay, so these are just some of the topics we'll cover at the stats one. And as I said, I've just updated that today. So we'll do 50 questions, but we'll cover over 60 topics. And lots of people have found this really gave them confidence in stats. Many have gone on to get 100%, 95%, 90% in stats. And these are some of the topics we'll cover in the admin. And again, lots of people, same format, 50 questions, 60 plus topics, gone on to get 100%, 95%, 90% plus in the admin domain. And then clinical, 100 questions, 100 plus topics, because sometimes I'll do one question, but I'll talk about 4 or 5 related topics, okay? But these are all topics that were mentioned by examiners in past examiner reports. So they're directly things that examiners have highlighted are important topics, okay? So that's running this weekend and then next week in the evenings. So time for a mini mock exam. We're going to do 10 questions. Again, it'll be 55 seconds per question, but this time the questions will move forward automatically. There'll be no polls. Just write down your answers at home with the question number. Because we've already done 5 questions, we're going to start at question number 6, okay? And then I will go through the answers and explanations for all of them at the end. Here we go. Okay, well done. Hopefully you've written down the question number and answers. So we're going to go through the answers and explanations. There won't be any polls for this section, so we can get through all 10 questions and then still have time to talk about revision planning. Okay, so I'll remind you of the question. Question number 6. So palliative care. In almost every single AKT ever, there's been at least 2 drug calculation questions. There has to be at least one by regulation in the exam, but there's usually 2 or more. So often there'll be 1 or 2 about pediatric type dose calculations, and then the other common type is something like this, an opioid conversion or palliative care cancer pain type question. Okay, so what we've got is someone taking 120 milligrams twice daily of modified release morphine, and their pain's well controlled. The reason they're changing now to a syringe driver is the nature of their disease now, the progression means they can't swallow. So the correct answer is C, 80 milligrams over 24 hours. CSCI is continuous subcutaneous infusion, i.e. a syringe driver can see it's just a slow amount over 24 hours, and it's subcutaneous rather than intramuscular. So the reason for that is, what's the total amount of morphine in this? 120 milligrams twice daily, that's 240. The conversion to diamorphine in a syringe driver is very straightforward. You just divide by 3. So 240 divide by 3, 80 milligrams diamorphine, and that's given over the 24 hours. Common mistake with this, there are 2. One is the wrong conversion. So people take 240, they divide by 2, and they get 120. That's the conversion if you were giving morphine by syringe driver or by injection rather than diamorphine. Remember, diamorphine is stronger. Okay. The other mistake is people miss that it's twice daily and they just do 120. So they've got the right conversion, but they're using the wrong base. So doing 120 divided by 3, they get 40. Okay. So this is the conversion taken from the BNF. So oral morphine, 30. If you're changing that to a syringe driver and you're putting morphine in that, because you can't put morphine in a syringe driver, you just divide by 2. Diamorphine, you divide by 3. And so 120 of oral morphine in 24 hours, converting to morphine, 60. Converting to diamorphine, 40. In this case, they want 240. To morphine, that would be 120. To diamorphine, it's 80. All right. So you work out the 24-hour oral morphine requirement, including any breakthrough doses, and then divide by 2 if you're changing to morphine, divide by 3 if you're changing to diamorphine. Genetics. So what's the mode of inheritance of hemochromatosis? Because that's key to getting this answer right. How is it inherited? Hemochromatosis is autosomal recessive. Absolutely, well done. Okay, and so what we see is that they're both carriers, the parents, and they want to know the risk that their children will have the disease. Not be carriers like they are, but have the disease. They're worried because they're both carriers. Do you see? And carriers may still have symptoms, but it's not as severe usually. So the correct answer is 25%. When both parents are carriers for a recessive condition, the chance that the child actually has full-blown disease, having the disease, is 25%. Whereas the second one in the set, number 8, remember extended matching questions come in sets of 2, 3, 4 or more. Okay, is in this case, they're asking what's the risk that their child, like them, is a carrier? Well, the risk that you become a carrier if both your parents are carriers for an autosomal recessive condition is 50%. Okay, so D is the right answer. So if we go through that visually, it becomes a bit easier. So look, mum's got a hemochromatosis gene and a normal or healthy gene. Dad's got a hemochromatosis gene and a normal or healthy gene because they're both carriers. So you get one from your mum, one from your dad. So you could be unlucky and you get the H from your mum and the H from your dad. 1 in 4 will have full-blown disease. There's a 50-50 chance that you get the H either from mom or dad and a normal one from the other one. You'll become a carrier. And then there's a 25% chance that you're fortunate, you get the normal gene from mom and the normal gene from dad. Not only do you not have disease, you now aren't going to pass it on to the next generation either. Okay, so that's autosomal recessive inheritance. And it's worth also knowing the modes of inheritance of the common and relatively important conditions for the UK population, but also finding out a little bit about these things. Okay, question number 9. This one, a couple of things I've highlighted here in terms of the importance of reading carefully. So first of all, it's a multiple best answer. So you have to get them both right to get the 1 mark. So which 2 of these would not be recommended as part of the diagnostic workup for this particular patient. So have a look at the symptoms. Something really important is her age. She's 38. Erratic periods, they stopped for a period, then they restarted again, also got some changes in her mood, and so on. What do you think the likely diagnosis is, or what is it that we might be doing a diagnostic workup for, given this history? Great. Premature ovarian failure, also known as premature ovarian insufficiency. Yeah. Because of her age. So, but what's challenging about this question, first of all, multiple best answers are hard in the AKT, because if you get one right and one wrong, you get nothing. There are no half marks. But secondly, this is negatively framed. So it's saying, look, most of these you would do as part of that workup, but there's two here that's not recommended in the guideline as part of the diagnostic workup for premature ovarian insufficiency. The correct answers are A and H. Now, most people pick H. And a lot of people, the reason they pick H is they think, I've not really prescribed that test, I've not ordered that test, or I've not really heard about it. And, if you're seeing something relatively common, you probably would have heard of it by now. So that's actually not a bad technique if you're really stuck in a question. But a lot of people, they pick this, but then they don't pick A. So then you get no marks. There's no half marks in the AKT, okay? So pelvic examination is not recommended in a patient like this, all right, as part of the diagnostic workup for this. You don't want to do an unnecessary internal examination. It's invasive, it's not pleasant. You need to have a good reason for it, okay? Whereas all of these are part of the standard workup. So when to suspect premature ovarian insufficiency? Someone under 40, they're not on the combined pill, and they've got sort of menopausal type symptoms. So that could be erratic or irregular periods, or they have periods where it stops, then it restarts. They may or may not also have some of the menopausal symptoms. So that could be mood changes, that could be things like hot flushes, night sweats. So initially, you'd look at FSH. So if it's 30 and above on 2 samples taken 4 to 6 weeks apart, then you'd think I'd do a full workup. And that will include things like luteinizing hormone, estradiol, prolactin, thyroid stimulating hormone, testosterone. What the guideline specifically says not to routinely do is not to do a pelvic exam and not to use AMH testing to diagnose. Okay, admin domain, GMC guidance. So this one, couple of things that are important about this is, again, it's a multiple best answer, so which two? But it's that sometimes people mix up different guidances that they might have read, and then they might get a question wrong. So the GMC tells us when we can and can't accept gifts. It doesn't say anything about value or amount. But GPs that work in a GMS practice, GMS is one of the 4 types of NHS GP practice: GMS, PMS, APMS, and PCLMS. These are the 4 NHS contracts. If you've got an NHS GP practice, you've got to have one of these contracts in order for you to have a mechanism to see NHS patients and to get paid by the NHS. Okay, the most common is GMS. GMS practice GPs, within the contract for the GMS practice, there's a sort of context that it says if you accept a gift worth a certain value or more, £100 or more, then you need to keep a record of that and have to have a register of gifts that you keep at the practice. But that's nothing to do with the GMC, which this question's about GMC guidance. You see, it's nothing to do with the NHS contract. You could get a question on that because that's fair game for the admin domain of the AKT, right? But this question is only about the GMC guidance. So which two does the GMC say? It says that if you get a gift that's given voluntarily from a patient or a relative of a patient, in some situations you can accept it. Some people have in their head you can never accept a gift. That's not true at all. We're coming up to that time of year. Many of you, if you're working in GP, you will see that you might not, because you've only been there maybe a few months, but you'll see that the partners, the salaried GPs, the regular doctors, that some of the patients that they've seen for a long time, around Christmas time, it's quite common that they'll come and drop off gifts. Okay. And F, that there's no maximum value set by the GMC of a gift that can be accepted. I think this is the one that sometimes people are surprised by, especially if they're just guessing rather than have actually read the guidance. Okay. Someone's asked a good question. Is GMS nationwide? Yes, GMS is nationwide and it's also the most common. So most NHS practices have a GMS contract. It's the most common one. So let's talk about the GMC guidance first. So it says that when you cannot accept gifts and when you can. So basically, you're not allowed to encourage patients to give you gifts. You can't pressure patients to make donations, even if it's to a good cause like a charity. You're not allowed to alter the management that you offer or the services that you offer based on a gift. And you shouldn't accept a gift if it might be seen as a conflict of interest or taking advantage. I don't accept a gift from someone who's got advanced dementia because they haven't got full capacity. As long as none of those are there and someone gives a gift voluntarily, you can accept it. And the GMC don't state anything about maximum value. Whereas if you're in a GMS practice, that's nothing to do with the GMC, then if you accept a gift worth £100 or more, you have to record that in a register of gifts. Okay, rheumatological disease. So key thing here is, given this background, what is it that we'll be looking for? So persistent synovitis, small joints of our hands. What is it that we'll be looking for? Rheumatoid, right? Great. So what's important is this: small joints of the hands and feet, multiple joints affected, and they're the small joints. Okay, so that's why the correct answer is A. And this one surprises a lot of people. So anyone with suspected rheumatoid, like the general baseline is they should be seen within 3 weeks. But there are some categories which are higher risk. They should be seen within 3 days. Okay, so anyone with suspected rheumatoid, you can start the workup, but don't wait for the results. Okay, they should be seen within 3 weeks. Who to refer even more urgently, i.e. within 3 working days? Anyone where the small joints of the hands or feet are affected. This patient, it was both. Or if more than one joint is affected. Or if they've already had symptoms for 3 months or more, because by this stage, they've probably already got significant disease progression. And so the sooner they're seen and they get onto disease-modifying anti-rheumatic drugs, the better in terms of arresting progression. Okay, so do you see, she met this criterion to get the ultra urgent referral, to be referred within 3 working days. Alcohol intake. So there's 2 ways that you can assess this. So one way is if you know roughly how many units are in common types of drink, then you can estimate it. And in some cases, estimating is enough. You don't have to get your calculator out. It can save you a bit of time. So if you know that a large, so 250 ml glass of wine at about 12% alcohol is 3 units roughly, and 7 nights a week they have this drink, and then on Saturday and Sunday another one with lunch. So how many glasses of wine in total? 9, right? So every night they have one, so that's 7. Then Saturday at lunch, Sunday at lunch, so 9, right? Okay, so if there's roughly 3 times 9, 27. Okay, so that's like, if you know how many are in common drinks, that's a quick way. And it's an estimate. It might not be exactly accurate, but it will be accurate enough for you to get the mark in most cases. I'm going to show you the formula if you want to be absolutely perfect. In this case, it's going to work out the same. So the formula is units of alcohol is the volume in milliliters multiplied by the percentage alcohol by volume. Take that total and divide by 1,000. So we've got, if I pull up my calculator, can you see the calculator on screen? Yeah, okay. So 250 mils times 12% alcohol by volume, okay? That gives you 3,000. Divide that by 1,000, and that tells you how many units, exactly 3. And then you just multiply it by how many they're having. So how many are they having? They're having 9. So again, we've already done that. 3 times 9, you all know, is 27, okay? Common reason why people get this one wrong, even if they know the formula, is sometimes people just see the 7 and you're in a rush. So you just do 7 times 3, they get 21. They didn't read carefully that on Saturday and Sunday they also have the same type at lunch. So that's easy to miss. Okay. So units of alcohol. Wine at about 12%, a small 125 ml glass is about 1.5 units. Therefore, a large 250 ml glass is about 3 units, roughly. Now, sometimes it'll be stronger, sometimes it'll be weaker than that. Then you can use the formula to be accurate. Beer, standard strength beer is about 3.5 to 4%. A pint of that is roughly 2 units. Premium beers and lagers, which are about 5 to 6%, a pint's roughly 3 units. Ciders are similar to that. A pint's about 3 units. Then spirits, 25 mils of anything at 40%, which is the most common strength of spirit sold in the UK, is 1 unit. And then the formula is there so you can do it accurately. Okay, so you've got someone with poor diabetes control, latest HbA1c is 70 mils. They're already on triple therapy, metformin, agliptin, aglitazone. So what would be a suitable regime? We're now going on to insulin. So a suitable regime would be keep them on metformin, stop the others, and then put them on NPH, neutral protamine hagedorn. Okay, it's one of the intermediate acting insulins, and keep them on the metformin. So B is the correct answer. So NPH is derived from a fish protein. Okay, and this is an intermediate acting. So you can either put it on as a basal regime on once daily or twice daily. So normally what I would do is if someone's been on triple therapy, not responding, keep them on metformin, probably stop most of the others, if not all of the others, and then start them on once daily at night. See how they get on. When you might go straight to NPH and also a short-acting insulin around meal times is someone's HbA1c is 75 plus. Theirs was 70. Then when would you consider a long-acting? So insulin detamir or insulin glargine, these are long-acting instead of an intermediate one like NPH, would be if they need help with injections or they're getting lots of hypos. And then it's important that they monitor their bloods morning and evening, because what you want to see is what's their control like. Otherwise, you might need to supplement this with bolus doses around meal times with a short-acting insulin. Type your answer for this one into the chat, because you've already done it, but type your answer. I just want to see what people get. Okay. So again, this is real data. I pulled this data from Public Health. This is the actual number of cases and deaths in 2020 that we had in the UK. And the reason that it says incidence of COVID-19 per million, because the WHO was collating data from every country. I don't know if you remember, there used to be those sort of tables and charts they'd show in different countries, the number of infections and number of deaths and so on. Okay. So they were reporting it in incidence as number of new cases per million. That's why it's the actual standard. All right. And what's important here, it says to the nearest whole number. So the correct answer, 41,560. So let me show you the maths behind that. First thing is to know that what is incidence? Incidence is new cases divided by the population. Okay. So we had 2,770,000 cases. Divide that by the population, 66 million and change. That gives us this value. Now, because it's asking as a rate, incidence per million, the last step is to take this number and multiply it by a million, which gives us 41,560.39. But it's set to the nearest whole number. And so to get the nearest whole number, what we do is after the dot, we just look at the first digit. If this digit is a 0, a 1, a 2, a 3, or a 4, then the nearest whole number is this number. You just stop there. If this digit was a 5 or higher, you'd add 1 to this number. You would go to 41,561 if this was 0.5 or higher. Okay, so in this case, it's 41,560. And if you put that in, whether you put the comma or not, you'd get the mark. Any other number, including if you put 41,560.39, you would not get the mark. This is marked by the computer because it asked for it to the nearest whole number. That was part of the test. Common mistakes with this. People look at this number. This number is totally irrelevant. This number will be irrelevant if they ask for COVID-related mortality, because that's deaths, you see. So it's there because there were the two metrics that we were measuring, but it didn't ask for mortality, it asked for incidence. So we care about the number of cases, okay, the new cases. That's what we care about. Then the other mistake is that people don't do this bit correctly, multiplying by a million. What they'll commonly do is they'll multiply by 100, in which case you would have got 4.1 and you would have rounded that to 4. What does that represent? Okay, if you multiply by 100, that's what you do when you're trying to work out a percentage, because it's always per something, right? Per million, you multiply it by that. Per 100,000, you'd multiply by 100. Percent just means per 100. That's all percent means. That's why you multiply by 100 when you're turning a fraction into a percentage, is you multiply by 100. Because percent means per 100. So incidence is the rate of new cases of a disease. You can either report it as a percentage or as a proportion of the population, per 1,000, per 100,000, per million, okay? And usually we look at it over a year. So like 1% per year means 1 in 100 every year. Or for rarer things, sometimes you give it in whole numbers. So 2 per 100,000 per year rather than 0.002% per year. So the way to calculate it, the number of new cases divided by the population. Then if it's a percentage, you multiply it by 100 because that's per 100. If it's per 1,000, multiply by 1,000. If it's per 100,000, by 100,000. Per million, by a million in that last step. Okay. And then prescribing in pregnancy. So we've got second trimester pregnancy, and she's got a sprained ankle. It's just asking about, ibuprofen over the counter. So the correct answer is D. It's now 20 weeks onwards that it's recommended that you should not have NSAIDs. Previously, it was contraindicated in the last trimester. Specifically, they said 28 weeks before. So those of you that picked E, you just might not be aware of the latest update, because actually, up until the latest update, this was the evidence. Okay, so up until recently, we were saying 28 weeks onwards, but it's actually now week 20. And this is a common area for examiners to pick questions from, is drug safety updates. Okay, so those of you that missed our recent GP update webinar, we actually did a special one just on drug safety updates. It's worth you going through that. We went through 7, 8 recent drug safety updates from the MHRA, the Medicines Healthcare Regulations Agency. So this is one of them actually, that they've always been contraindicated for a long time in the last trimester, specifically 28 weeks onwards. The risks being premature closure of the ductus, renal dysfunction in the baby, prolonged bleeding time for the mother, and it can impact contractions, making a longer, more unpleasant labor. And the types of things are NSAIDs as a class. Doesn't matter if it's oral or injected, any NSAID. But the latest data basically says that there's risks even from 20 weeks onwards. And those are that it can reduce fluid, and that can impact, the risks to the baby. This is because of renal dysfunction, and that it can also cause constriction of the ductus, can cause heart dysfunction. So they now recommend, if someone might not know this and have been taking it over the counter, even from 20 weeks onwards, they should have increased antenatal monitoring, and that we should avoid prescribing it after 20 weeks and advise patients don't take it over the counter. Stick to something like paracetamol. Okay, so add up your score, get a number out of 15. Okay, you've including the 5 that we did before the mini mock. I'll give you 30 seconds to do. Okay, so if you got 11 or more, that would be a pass on any sitting historically. Now, we've only done 15 questions. Remember, the real exam's 200, right? Okay, but that it would include the latest sitting of the AKT, the October one, that had the highest passed mark ever. It was set at 72.5%. Before that, the last 20 years, the highest was 72%, and that was only once. Usually it's 71, 71 and a half, 70, around there. A few times it's been 69, 68. The lowest it's ever been is 66. But the highest it's been so far is 72 and a half. Well, 11 is just above that. 10 is borderline. It would be just below in the last sitting, in some recent sittings, and in most sittings, actually, it would be a fail, because that sits at about 66 and a bit. So only when it was at the lowest it's ever been, 66, it would just be a pass. But in most sittings, it would be a fail. 9 or less, you're not there yet, but don't worry. You're not sitting the exam tomorrow. And we've only done 15 questions. And of course, if I'm going to make it high yield learning, I'm going to cover 15 topics that we know people struggle with. We're going to do harder topics and harder questions, because then there's more to learn, right? Hopefully, you've got a clearer idea, though, of some of the exam technique that we've talked about. You updated you on some topics you might not have known. We've covered several things that have changed very recently. And also, you might have picked out some gaps in your curriculum, so you can go and fill those. So in terms of revision planning for the last 8 weeks, by this stage, you should have covered a good chunk of the curriculum. So what you want to do is systematically continue to cover curriculum topics so that you can cover it all before you get to the exam. And any areas that you're less confident in, your weaker areas, as well as going through them, you want to make time to maybe go over those ones again to revise them. You definitely want to revise the key topics in stats, admin, and all the clinical topics that examiners have mentioned that often get frequently retested. Last 30 days before the exam, go through the AKT 30-day challenge. So we have them on our YouTube channel. Do one a day, 5-10 minutes it takes, but this is a good way. We've built them to cover 30 high yield topics, and then work on exam technique by doing some practice questions and doing timed mock exams. I recommend as you come close to the exam, doing one mock exam, each weekend. So we've got our AKT checklist. It's got like the 600 topics that most commonly come up from the exam, and important topics from clinical stats and admin. You can make sure you can use that as a checklist to make sure I've covered everything systematically. And then our high yield topics checklist covers the topics that examiners have mentioned in examiner reports. These topics come up a lot. They get retested again and again. So again, make sure you've covered all of those. So if you want to read, a specific guideline, you want to use national guidelines, and like NICE, that's the source that they will use for a lot of questions. If you want to cover a lot of them efficiently, if you're not already got our clinical case cards, then that's a quick way to do it. So, our team got together and looked at guidelines, and we put together sort of very concise. They're pocket size. So, you fit this in your bag, you can fit it in your pocket. There's a printed version, there's a digital version, there's a bundle that includes both. But it's the kind of thing you could do in between patients. You could look at a topic and revise it. Okay, they're updated. The current edition is from 2024, so they're up to date. Here's some examples. And then if you found, I mentioned the one question at a time is how our masterclass webinars work. Our AKT 200 mock crammer, which is going to happen early in January, about 3 and a bit weeks before the exam. That works how, we did the 10 question mock. We do one question after another, and then we go through. We do it like that, but rather than 10, it's 50 question mini mock in one go, 50 questions one after the other. Then I go through answers, explanations, and you get the topic review as slides. Then you have a break, then another 50, then lunch, then another 50. And so by the end of the day, you will have covered over 200 topics, but you will have done 200 questions in the same proportion as a real exam, i.e. 160, 80% clinical, 20 stats, 20 admin. And then you get access to another full 200 question online mock with 200 different questions. Okay. And so if I just put those together, for those sitting for the January exam, we've got our AKT Pass Plus bundle, which includes all of the masterclass webinars, plus the 200 grammar, plus the recording of our full day AKT course, which ran 2 weekends ago, in case you missed that one, plus a half day sort of AKT masterclass webinar, and then our online questions and 3 full mocks and the printed case cards. That's our Pass Plus. You save nearly £400 compared to buying all these things separate as a bundle. Our booster bundle includes the AKT 200, the 4 masterclass webinars, and a full mock afterwards. And then our masterclass bundle includes the 4 webinars: stats, admin, high yield clinical 1 and 2. So you'd save in any of these compared to buying them separately. But there's different things in them. Okay. So any other questions, please put them into the chat. Otherwise, we're going to wrap up now because it's time. And I leave you, for those that haven't got questions, with this message from Muhammad Ali as we get close to that critical period where we've got sort of 8 weeks to go. That don't count the days, make the days count. Make the most of every single day between now and the exam. That make sure every day you're doing some questions, you're revising some topics, you're doing a balance of practicing questions and reading to make sure you understand, especially the areas in questions you get wrong. Don't let a single day, even if you've had a busy day, you've got an on call, you could do something. In your break, you can revise 1 or 2 case cards. You can do 1 set of questions in the evening or before you go to work if you've got a late shift. It doesn't matter what else is going on. It's just on days when you haven't got such a busy, you're going to do even more. But don't let a single day go where you don't do something. Okay, because the sacrifices that you make now, they're going to be worthwhile when you get that green tick, you pass your exam, and you move on to the next stage of your training. And the fun part of GP is life after CCT. It's not these 3-4 years, it's the next 35 years. Okay, so don't count the days, make the days count. Make the most of every day, keep pushing, keep going, prepare, and you will succeed.